All right, let's jump right in. Welcome back, high-yield learners. Today, we're tackling a really fascinating and absolutely essential medical board review topic. It beautifully connects genetics, cellular biology, and systemic pathology. We are demystifying cystinosis, a rare but incredibly important lysosomal storage disorder. Whether you're prepping for the wards or an upcoming exam, this explainer is exactly what you need to know.
Here's our quick roadmap for today. 1. The clinical vignette. 2. Genetics and pathophysiology. 3. Organ manifestations. 4. Diagnosis. And 5. Treatment and exam pearls. Let's get to it.
Section 1. The clinical vignette.
Okay, picture this. You have a seemingly healthy infant, but gradually they start drinking excessive amounts of water and urinating constantly. As the months pass, you notice the child's growth is really slowing down and their bones are becoming weak. By the time they hit school age, progressive kidney failure has developed. And then, a careful eye exam reveals a stunning, yet really alarming finding: sparkling crystals distributed throughout the cornea.
Take a second to just think about that sequence of events. What single unifying diagnosis connects an infant's profound thirst and bone weakness to pediatric kidney failure and sparkling eyes?
The answer is cystinosis. This is a rare autosomal recessive lysosomal storage disorder. But here is the critical distinction you absolutely must remember for your exams. Unlike many lysosomal storage diseases that are caused by missing enzymes, cystinosis is actually caused by a defect in a lysosomal membrane transporter. The cell simply cannot transport the amino acid cysteine out of its lysosomes, and that bottleneck leads to massive crystal accumulation across multiple organs.
Section 2. Genetics and pathophysiology.
Let's think about the stark contrast between a healthy cell and an affected one. Normally, proteins get degraded inside lysosomes, which releases amino acids. A transporter protein called cystinosin then ushers that cysteine right out of the lysosome so the cell stays healthy. It's like a cellular recycling center. But in cystinosis, that cystinosin transporter is either completely defective or just absent. So the cysteine gets trapped. And because it's poorly soluble, it forms these sharp crystals. These crystals physically tear up the lysosomes, trigger oxidative stress, disrupt normal cellular cleanup, and induce apoptosis, eventually leading to progressive tissue fibrosis. And since the proximal tubular cells of the kidney naturally have super high lysosomal activity, they are almost always the very first cells to be destroyed.
So how is this actually passed on? Well, cystinosis is caused by mutations in the CTNS gene, which makes cystinosin. Because it's an autosomal recessive disorder, typically both parents are just asymptomatic carriers. That means for every single pregnancy, there's a 25% risk of having an affected child, a 50% chance they'll be a carrier, and a 25% chance they'll be completely unaffected. Now, not every case of cystinosis looks exactly the same. We generally group them into 3 main types. The most crucial one for clinical practice, and definitely the most severe, is infantile nephropathic cystinosis. It's the most common form. Symptoms kick in within the first year of life, driving early, aggressive kidney disease. Then we have the juvenile or intermediate form, which has a later onset and a much slower progression. And finally, there's the ocular, or non-nephropathic form. This is the mildest variant. The kidneys actually stay perfectly normal, and the main feature is really just those corneal crystal deposits.
Section 3. Organ manifestations.
The absolute earliest manifestation you are going to see in the infantile form is renal Fanconi syndrome. The proximal tubule is failing, leading to this massive loss of essential substances right into the urine. The patient presents with polyuria, polydipsia, dehydration, and failure to thrive. On their labs, you'll see metabolic acidosis and hypokalemia. But here is your massive red flag, a classic exam pearl, guys. You will see glucosuria, meaning sugar in the urine, while their blood glucose is completely normal. There's no way around it. That, along with phosphaturia and amino aciduria, absolutely confirms the proximal tubule is dysfunctional. And left untreated, this marches straight toward end-stage chronic kidney disease in childhood.
Once those cysteine crystals disseminate, you really see the multi-system nature of this disease. Because of all that phosphate lost through the kidneys, the bones suffer immensely, leading to rickets, bone pain, fractures, and stunted growth. Up in the eyes, those trapped crystals cause severe photophobia, literal pain from light, and a constant foreign body sensation. The endocrine system takes a major hit too, leading to hypothyroidism, diabetes, delayed puberty, and hypogonadism. Even the neuromuscular system is compromised, resulting in distal muscle weakness, swallowing difficulties, and myopathy. It is truly, from top to bottom, a whole-body disease.
Section 4. Diagnosis.
So, Fanconi syndrome has raised our suspicion. How do we confirm it? You have a very specific diagnostic toolkit here. The absolute gold standard test is measuring the cysteine concentration inside leukocytes, the white blood cells. If you see markedly elevated intracellular cysteine, boom, you have your diagnosis. You'll also use genetic testing to pinpoint the specific CTNS mutations, which is incredibly helpful for family screening. For an immediate clinical clue, an ophthalmic slit lamp exam is pathognomonic. It reveals those brilliant refractile corneal cystine crystals. You might use x-rays to confirm rickets or ultrasound for nephrocalcinosis, but actually, a kidney biopsy is rarely needed to make the final call.
Section 5. Treatment and exam pearls. So, the crucial point is, what do we actually do about this? Well, treatment has completely transformed the survival rates for these patients, and the absolute cornerstone of that is cysteamine therapy. The mechanism here is just elegant. Cysteamine enters the lysosomes, physically reacts with the trapped cysteine, and forms new compounds that can actually exit the lysosome through alternative transport pathways. It's like building a backdoor escape route. By clearing out that intracellular buildup, cysteamine drastically slows down kidney damage, delays end-stage renal disease, and protects the other organs. Starting this early is, for sure, an absolute game changer.
Of course, comprehensive management is multifaceted. Because oral cysteamine doesn't reach the cornea very well, we have to use topical cysteamine eye drops to clear out those painful eye crystals. We also aggressively replace all those urinary losses from the Fanconi syndrome. We're talking fluids, sodium, potassium, bicarbonate, phosphate, and vitamin G. We manage any endocrine fallout, like hypothyroidism or diabetes. And eventually, if end-stage kidney disease does occur, a kidney transplant is a fantastic option. But, and this is a massive caveat for your exams and your future practice, a new kidney does not cure the underlying systemic genetic defect. The new kidney itself won't get the disease, sure, but the rest of the patient's body still has that DNA, so oral cysteamine therapy absolutely must continue for life.
Now, let's do some rapid comparative pathology. Differentiating these exact features will earn you major points on test day. Think about cystinosis, Wilson disease, and Fabry disease. They all have unique stored materials, specific genes, and hallmark clinical presentations. Cystinosis stores cysteine. It's driven by the CTNS gene and hallmarks with Fanconi syndrome and corneal crystals, treated with cysteamine. Wilson disease, by contrast, is an autosomal recessive disorder that stores copper, mostly affects the liver, gives you Kaiser-Fleischer rings, and is treated with chelation. Fabry disease, that one is X-linked, stores GB3 from a GLA mutation, presents with a burning neuropathy and cornea versilla lata, and uses enzyme replacement therapy. Keep these distinctions in your mental back pocket.
To really anchor everything we've covered today into your long-term memory, let's run through the ultimate mnemonic, cysteine. C stands for corneal crystals. Y is for young child presentation. S reminds us it's a storage disorder, specifically lysosomal. T is for tubular Fanconi syndrome. I means it's inherited in an autosomal recessive pattern. N is for nephropathy, and E is for eye involvement. If you can just recall this one single word on exam day, you can essentially outline the entire pathophysiology and clinical presentation of the disease.
And that brings us to the end of this explainer. Cystinosis is rare, and it's heavily multisystemic, but it is highly treatable if it's caught early and managed comprehensively with cysteamine. I really hope this breakdown made the complex pathophysiology clear, approachable, and memorable for you. Now I want to hear from you. Which lysosomal storage disorder or complex nephrology topic should we demystify in our next explainer? Keep learning, keep questioning, and I will see you in the next one.